The next thing we'll be talking about is tuberculosis and drugs that take care of TB. And this discussion starts on page 78, anti-tubercular drugs. You see on page 79 that we've got figure 5.2 that shows about transmission of tuberculosis and how things can affect the lungs. And we think of TB as primarily being a pulmonary disease, and for the most part it is, but it can also settle in other areas too. Anti-tubercular drugs. When we're talking about tuberculosis itself, tuberculosis was an ancient disease. When archaeologists dig up bodies in various cultures that have been preserved, signs of TB have been found all over the world, and it's been around for a long time. And up until fairly recently, it killed a lot of people. We know that the old-fashioned name for TB was consumption, because people would get very thin, very pale. It particularly ravaged people who lived in crowded conditions and people who were very poor, but it was not a respecter of persons, and plenty of other people in other situations ended up with TB too. However, in the 20th century, we did get it under control, and it was under control for years. Unfortunately, it's coming back now, and one of the reasons it's coming back is because HIV patients are very vulnerable to TB. But generally it's endemic in underdeveloped nations and with people who live in very crowded living conditions. The high-risk groups for TB nowadays are immigrants who come from one of these countries where TB is commonly found, drug users because they're in a debilitated condition. They often gather in very crowded circumstances, and some of them have been in and out of prison. HIV patients, of course, because their immune systems are compromised, and then any group living in crowded living conditions are going to find that it's easier to pick up TB. The etiology of tuberculosis is a bacteria known as Mycobacterium tuberculosis, or M. tuberculosis. Once a patient gets TB, parts of the bacteria called tubercles remain in their system for life, or remain in their immune system. And so if you give a PPD test, purified protein derivative, where part of the cell membrane from M. tuberculosis is injected under the skin, the patient's always going to react. So the PPD test that we as healthcare providers have to get every year is not looking for active disease, it's looking for exposure. And so if you react, then further tests have to be taken. If you look on page 79 at the memory jogger, we see the symptoms of active TB infection. And so that's pretty obvious when you've got a patient who comes into the hospital and they have a productive cough, they report bloody sputum, they tend to lose their appetites and have weight loss. And a feature of TB is running a fever off and on with chills and a lot of sweating at night, but other things will do that too. So most hospitals and other facilities have a TB screening process where you ask questions of your patients and they tell you if they have these symptoms, and like anything else, you hope your patients are being honest with you. Now, on pages 80 and 81, we see a list of the most commonly given anti-tubercular drugs. Most of these drugs are bacteriostatic. They work either inside or outside the cell to prevent the organism from being able to protect itself properly. And we learned when we talked about antibiotics that anytime an organism, the pathogen, can't build a strong cell wall, it's going to be weakened, it's not going to be able to reproduce properly, and the growth and spread of that bacteria is going to be affected. Now, some of the anti-tubercular drugs are bactericidal, but most of the ones that they're using nowadays are more bacteriostatic. So what you end up doing is needing a variety of drugs for a long period of time. Just one drug for 10 days or 2 weeks isn't going to do it. These folks are on these anti-tubercular drugs for 6 months to 2 years in some cases. Now, the length of treatment varies depending on how long it takes for a patient to give a negative sputum result, but the Knox County Health Department has this policy for active TB, where the bacteria is working in the lungs or in other body parts. They're going to use the 4 drugs listed on pages 80 and 81 in your book for 2 months, and then they're going to switch to just the first 2 drugs, isoniazid and rifampin, for 4 months, and then they test and see what your sputum samples are looking like. If a person has latent TB, that means the tubercle is present in their body, it's making a reaction to PPD, but yet it is not causing active disease or spreading to somebody else, but the possibility is there for it to come up later. The person will be put on 6 months of isoniazid. So just to make sure that you look at these 4 drugs, we've got isoniazid, rifampin, pyrazinamide, and ethambutol. Those are the big 4 that they're going to start off an active TB patient with. And then they just have to do it on a case-by-case basis, bring the person in and continue to look at their sputum cultures. On page 81, we have some lifespan considerations for pediatric patients, so make sure you read that. The pediatric patients who usually get TB are children who are living with people in those high-risk groups. Now, there are a couple of ways you deal with TB. We're used to the term chemotherapy as talking about active disease, and usually, of course, we're referring to the treatment of drugs for cancer. But chemotherapy really refers to the treatment of chemicals or drugs for any kind of active disease. So if you have a patient with active tuberculosis, you're going to have to provide that person chemotherapy in the form of one or more of these drugs found on pages 80 or 81 in your book. If they have latent TB, if they show that they have been exposed to it in the past, even if it's not active now, they're going to have chemoprophylaxis, which is the use of drugs to prevent the disease from becoming active, and that's where the 6 months of isoniazid comes in.